Hi everyone, my name is Ashley Son. I am a research data analyst at Aspire, and I will be presenting our project on the automatic segmentation of rectal tumors on MRIs. The accurate detection and segmentation of rectal tumors on MRIs is essential in clinic for staging, treatment planning, and assessing treatment response. It is also important in research for radiomic and deep learning models. Manual segmentation, however, is very labor-intensive, time-consuming, costly, and requires the expertise of a radiologist. Recent advances in deep learning have shown promising potential as alternatives to manual segmentation methods, specifically the nnU-Net, or nnU-Net. The nnU-Net is a widely used deep learning-based segmentation method for biomedical imaging with automatic self-configuration. In this study, we trained a 3D full-resolution nnU-Net to automatically segment rectal tumors on MRIs. We collected clinical data and MRIs from 37 patients enrolled in the Short-Fox rectal cancer treatment trial at Stanford. This trial consists of a new treatment approach with the goal of increasing clinical complete response rates and eligibility for organ preservation. In our cohort, there was a total of 10 patients who achieved clinical complete response and 27 who did not achieve clinical complete response. A significant portion of these patients were older, and the majority were male. Additionally, most of the tumors had a clinical T stage of T3 as detailed in Table 1. Figure 1 illustrates an axial T2 small field of view oblique pelvis MRI of a 30-year-old female with a T2NO tumor. The tumor is indicated by the white arrows. Figure 1b is the MRI overlaid with the manual segmentation of the tumor shown in green. We manually segmented the tumor on a segmentation platform called Slicer. First, we detected the tumor based on the annotations and reports in Epic. We were then trained by Vipul, a radiologist here at Stanford, on how to delineate these tumors in 3D. These segmentations were then reviewed by him. Figure 1c is the MRI overlaid with the nnU-Net segmentation in red. To train the nnU-Net, we first resampled all images to a uniform voxel spacing, then filled in all holes in the segmentations. We then performed a 5-fold cross-validation. Figure 1d is the volume overlap between the manual segmentation in green and the nnU-Net segmentation in red. The dissimilarity coefficient here was 0.79. We used the dissimilarity coefficient to determine the agreement between the manual and nnU-Net segmentation. Shown in equation 1, the dissimilarity coefficient is 2 times the intersection of A and B over the sum of A and B, where A is the nnU-Net and B is the manual segmentation. For the training cohort, the nnU-Net detected all 37 tumors correctly. The median dissimilarity coefficient for the nnU-Net and the manual segmentation was 0.7, with an interquartile range of 0.42 to 0.74. We are now confident to use this model to detect and segment rectal tumors automatically. This study has some limitations. First, it is a retrospective study and subject to potential selection bias. Second, it is a very small single institution dataset, and its reproducibility across different institutions remains to be evaluated. We are now in the process of collecting additional scans from Stanford to increase the sample size. The nnU-Net can also take input from multiparametric MRI, such as T1 and diffusion-weighted imaging. Moreover, the nnU-Net can also be adapted to incorporate imaging at multiple time points. We plan to add T1 and diffusion-weighted MRIs along with pre- and post-MRIs. In conclusion, we present a 3D nnU-Net to automatically segment rectal tumors on MRIs. We plan to use this approach to develop radiomic and deep learning models to improve treatment response evaluation with the potential to inform personalized treatment.